we're here just to explore this new kind of audit that Mo is here to talk about, and I'll demo a bit later. It's about the care navigation project, just to see what undocumented work we're doing to redirect patients to the correct pathways. Um, it just helps us gather evidence effective at a national level. So there's an audit happening in Manchester. There's an audit that we're going to start very shortly. So Mo from Loxu is just here to just talk about it. He's got a presentation, so I'll thank you for attending, Mo. I'll hand you over to Mo.
Thank you very much for your time. I'm just going to share my screen. There we go. And it is just let me know if you can see that. Yep, perfect, brilliant. So, evening everyone. So first of all, thank you very much for joining us. I'm Mohammed Bouta. I'm speaking here on behalf of Loxu, and I'm working together with the two Southeast London LOCs, which are BBG and LSL. And we're working in partnership with Charles at Primary Ophthalmic Solutions and the Central Optical Fund as well. Now, the session is about MEX care navigation data collection, and it's a project that, as Pritesh said, we're doing in Southeast London, and we're doing another project up in Manchester. I'm going to briefly explain today why we're doing the project, what we mean specifically by care navigation, and most importantly, what we expect practice to, how we expect practice to work during this project. Intention, we're not trying to change the way that people are working. It's not a new way of working. It's rather reinforcing the normal business as usual way of working, and to ensure that all activity that's taking place at first contact with a patient within the MEC service is recorded on a consistent basis. And then we'll have time for some questions, etc. at the end. Hopefully not that there should be many, I'm hoping, but we shall see. Moving on. There we go. So firstly, care navigation, it's already part of everyday practice. And it's the first contact when practices help patients reach the most appropriate next step. Now, that may be that a patient presents with a problem and they are suitable for the MEC service. It might be that another route is more appropriate. For example, a site test, a contactless aftercare. They might be deflected to self-care, to pharmacy, to the local hospital. Um, the issue with regards to this project is not that this work isn't happening. We know it's happening. The issue is that potentially it's not always been recorded on a consistent level, which means that some of the value isn't visible in the routine data that we have on a national level. The reason for this project, therefore, is designed to capture and understand exactly what type of activity is occurring. As I said, and I want to be really clear, we're not replacing any part of the MEC service. We're not creating a new pathway. It's just about making sure that we reinforce good practice and make that activity that lots of you are doing in primary care currently more visible to everyone. Now, care navigation, what is it? So specifically in this project, when I say care navigation, I'm talking about helping the patient reach the right eye care pathway at the right time and in the right place. And it's through it can be a very structured first contact sort of conversation. The exact next process, I can understand, will vary between practices. Some practices have different ways of recording that initial triage, that initial contact, and that is absolutely fine. The purpose, though, is to make sure that that process, when that patient attends, is consistent, and understanding why the patient is contacting the practice, making sure that there's any clinical escalation, making sure that when you do identify any clinical escalation, it's going properly, and directing the patient safely to the appropriate next step of that process. Care navigation is not about diagnosis. It's not about clinical decision making by a non-clinical member of staff. The clinician remains responsible for all clinical decisions at all time. Think of it a little bit like your GP practice. You ring up, you have a headache, you have a tummy ache, you've got your receptions, which we call, I know some people quite call them guard dogs or whatever, security guards, etc. I've heard all sorts of names being GP reception staff being called, but ultimately what they are doing is care navigating, and it's no different to what we do pretty much in primary care day in, day out. But as I said, that consistent recording is probably not happening. Um, Now, the main message that I want people to take away is there's no locally agreed script. So you don't ask a set series of questions to every patient that attends. Practices should continue to use the locally agreed MEX processes, including any existing questions that you have as part of your employer, as part of your practice processes, your SOPs, any internal workflows that you have as a practice. You don't change any of that. The main point is that that first contact is to, as I said, to understand the reason why that patient has come, to make sure that there's no red flags or anything else that requires a clinical escalation to a clinician immediately, and to make sure that we're directing the patient to the most appropriate route in that service. The safety principle, I can't stress enough, does not change. Any doubts, any sort of queries with the front of house staff, and that should be escalated pretty much immediately. Okay. Now, what does good look like? So, a practice would, a patient would contact the practice. Okay. Again, explain to the patient why questions are being asked. So, just a quick brief example. I'm just going to delve a little bit more into your eye concerns so we can understand where better to direct you. You follow your local processes, your practice processes, your SOPs, whatever you have that you currently use. And then the team should book or signpost that patient through to the appropriate route. They don't interpret any symptoms. They're not providing clinical advice, and you're not assuming a diagnosis. What we don't want is people at the front desk to think, oh, this is potentially a conjunctivitis, etc. That all goes out the window. You're dealing with the patient in front of you and with those structured questions that you may have asked them as part of your local process. The clinician provides input wherever the process requires it. So wherever you normally have clinician input, some people will triage every single patient and run it past a clinician. And if that's what you do, then you continue doing that, especially if there's any red flags or any uncertainty about the patient's symptoms or exactly why they've presented. And then what we would like you to do is make sure that you record the agreed outcome in farm outcomes, which Pritesh will take you over a little demo in a moment, hopefully quite light touch and very easy to do in practice. And the recording point really matters because it's that activity that we are measuring here. If you don't record it, it can't be included in this data collection. Okay. Now, escalation. Sorry, you know what? I've just realized my slides haven't been moving forward, have they? There we go. Right, I'm going to jump forward. So escalation, as I said, I'm going to repeat this point again. It's the most important patient safety safeguard that we have in this process. A red flag, and you immediately involve a clinician at the first available opportunity. If a member of team is unsure about the eligibility of that patient, about the urgency, about what route they should go down, then not to guess, the clinician gets involved. And same applies, obviously, if a patient is under the care of the hospitalized service or if they're asking for clinical advice from a clinician. Okay. Escalation as part of a care navigation pathway is not a failure point. It's how safe care navigation should, in effect, be working across every healthcare setting. Now, what do we need from all of you? Hopefully, really, really simple. Before the project begins, just want to make sure that everybody who receives, who provides that first line MEX contact understands the processes, knows when to involve your clinician, and knows how the outcome should be recorded. During the project, if you can please continue to work in line with your normal MEX arrangements. And then the main additional ask is to make sure that the care navigation outcomes are recorded promptly and consistently and in a contemporaneous manner, please. And if you do encounter any practical issues, then if you please raise it as early as possible, try to resolve that problem sooner rather than later. If you please flag it. Charles, I don't know if you've sent out a contact email address, if that's yours or whoever's, but I'm more than happy to provide my details as well, but we can work that out afterwards. But please do get in touch if there's any doubts whatsoever. With regards to payment, I just want to stress again that this work has been supported by grant funding from the Central Optical Fund. Okay, and that's been secured by LOXU. The funding is what enables us to run this project and do the data collection and evaluate the learnings from this small project. Participating practices will receive £10 for each eligible recorded care navigation episode. So that is a patient who does not enter the service at that initial point of contact because they do not require a MEX episode. So for example, a patient comes in, you think they might be eligible for MEX, you go through your set process in practice, and it turns out that that patient doesn't actually need a MEX for whatever reason. And you say, look, I think you need a site test, you need this, you should go to the pharmacy. And again, please do look at your local specification. And if in doubt, do get in touch with your LOCs, and I'm more than happy to support them as needed. The important point again is to make sure that the relevant outcome is recorded so that we can identify and validate the activity that's occurring. Payment will be made by Primary Ophthalmic Solutions to the practices, to the participating practices for all verified episodes, and that funding will then be reclaimed by the LOCs and by POS from LOXU. Okay, just to make that very clear. And again, just one last thing, it doesn't change your normal MEX claiming. So this doesn't impact how you normally claim for your current MEX. And it's not paying for any clinical decision making. All we are doing is recognizing the work that's involved in making sure that we're recording those care navigation outcomes on a consistent manner day to day. Okay. That's me done. Questions, please. So any questions you have, I'm more than happy to take. If any questions come up later, Charles, please do make a list and pass them over to me, and I will respond back to them as early as possible. But again, just to reinforce, please continue providing the safe, normal practice that you currently do within your existing service. All we want is that initial capture where patients do not enter your service, and we just want to know exactly why that is, and how often, how many times that is happening, so that we have that national data to use for further review and learning from these services. Thank you very much. I'm not seeing a deluge of hands up here, which is good, I guess.
Yeah, I think that was very clear. Thank you. Thank you, Mo.
Yeah.
I appreciate that. I just want to, yeah, thanks everyone for agreeing to do this. And I just want to show you what the module looks like on farm outcomes. It's fairly straightforward. It's basically weekly reporting. If you could,
I'm going to stop sharing now. Yeah.
Mine, yeah, great. And then I'll share my screen and show you.
I'm just figuring out how you do this in. Oh yeah, there we go. Got it. Brilliant.
Okay, thank
Over to
you.
you.
So let's figure this out. Okay. Screen over. So this is farm outcomes. This is my practice. This is what it looks like. You will see a new audit service here called Patient Care Navigation. And it's not daily reporting, it's weekly reporting. So you'll need to kind of make a list of this kind of stuff. And we're just taking all this data basically. So every week, it's for a month. I think we're starting, was it 1st of September? I believe, yeah. So these dates will change. I've got to change that, okay, because we were supposed to start in June, but we decided to delay it. Okay, so that will change over to 1st September, and then weekly from there for 4 weeks, effectively. Just basically record this stuff every week. Okay. you'll need to keep a record separately of this. I haven't. I didn't want to kind of get it recorded every day simply because it's something else to do, but you'll need to kind of record it in a spreadsheet or your diary or something like that. Just say, okay, yeah, I care navigated this many people, and this is where we navigated them to effectively. And yeah, you want to compare that to the number of next episodes you can see this week. We might be able to audit that or pull that manually, but I think it'll just be easier if you can record it here, so it's on one spreadsheet, and then Mo can audit that from his perspective there. And then once you've filled it all out, just click save. Done. Simple. Okay, so please once a week, just try and record this and just see where things go from there. Okay.
Brilliant.
Any
Thank you
other?
for your attention. I think the key is to try and make this as light touch as possible, isn't it? We want to try and make sure that we keep it really light for practices. We understand you've got enough to be doing, so it's just about making sure it's really easy as possible. If you do have any feedback, please do pass it over. So,
Lovely, thank you. I'll stop. Anyone else have any questions at all? Well, anyone have any questions? Yeah.
oh, does it look okay?
Shall
Do you have
we?
any questions, Pritesh?
No, not really. It's very straightforward.
Yeah.
Was there a demand for this? Did someone ask what value is it in a mech service if you're just going to see the patient and not do anything else with it? Or because what prompted this? I'm just interested.
Yes, absolutely. So, I mean, so I'll speak for where I work. Okay. So where I work, we have a queue service, as opposed to Mex, and we do find that in practices, people are very busy and they're not always recording using the supplied software, purely because they're too busy. So if they are going to, if a patient's going to enter the queue service to get paid for that episode, they have to enter that patient on the platform, and therefore they will quite readily and accept and understandably do that. But if the patient isn't going to enter the pathway at all because they don't need to, then what's happening is that we're not having that evidence, that recording element going on because of the administration burden on practices, and it's just easier not to do it. They record it in the patient notes. At the end of the day, you've covered yourself clinically. They'll make good notes there. And it's that lack of evidence that we have about exactly how many people are being diverted away from services. And as we're discussing MEX and Q services with more commissioners, in a few areas there have been decommissioning talks on these types of services. And what we'd like to do is provide the evidence that, look, wait a minute, it's not that you're seeing 100 patients and 100 patients are entering the queue service. We're actually seeing 130 patients, and out of those, only 100 patients are entering the queue service, or MEC service, and 30 of those are being care navigated away to either pharmacy, to self-care, to warm compresses, what might you, because they don't need a full-on queue service. So it's about that hidden element of that service and the saving that the commissioner makes that isn't evident to them. All they see is the money that's going through, not the money that's being saved.
I think it's important to have every member of your practice on board so that all these interactions are recorded. So basically, we can prove the value of what we do again. So, yeah. So just please impress on your practice staff that this exists. It's only for a month. Do your best to record every outcome, and we will have some nice evidence.
And then if you do have any other colleagues in South East London who provide the service and who'd be interested in offering, please do pass their details over to Charles, to Pritesh, to Chris, everyone, just to make sure that we get as many people an opportunity to participate in this as would like.
Lovely.
Brilliant. Does that mean we can give everybody over half an hour back of their evenings?
So thank you so much. Thank you for that.
Super.
Okay. Thank you very
Thank
much.
you very much for
Yeah,
joining. Thanks for all your work,
thanks, Stu.
LOCs and Charles. And yeah, thank you very much, everyone. And good luck.
Take care.
Take
Bye.
care. Thank you very
Thank
much.
you.
Thanks.
Thank you. Bye.